Okay, so we'll start out with nutrition, which makes sense. And I want to go through the objectives and also show you the updated study guide, and then kind of give you the areas where I would like you to focus. And let's go back. And so we're pretty much focusing on GE reflux. And sorry if I turn my head, I've got two other screens I'm looking at. GE reflux, the cholecystitis, cholelithiasis, and then the peptic ulcer disease. We also talked about celiac disease, and then I did add into the study guide about bariatric surgery and dumping syndrome. That was something I think actually that that Brad had asked about, and I would like to add that in. So I added what I want you to know on the study guide. So let me.
Oh, so it's Brad's fault. Okay.
Yeah, pretty much. I don't know. What do you see on your screen now? Is it concept connections, or is it still the week 13 lesson?
I see concept connections.
Thank you, Celine. Okay, so one of the first objectives was to look at how the concept of nutrition relates in term excuse me, I'm sorry, in terms of like nutritional concerns and like patho that also impacts, sorry, long day, that's impacting nutrition. So with GERD, we know that's reflux, right? Coming back up, whatever you've eaten, and then looking for, it's usually like acid, irritants, things that you are eating. And then we did talk a little bit about esophagitis, where it can also affect your esophagus because of all the acid coming back up to where you might need help with that. The pyloric stenosis, we're not going to cover because we covered that already. The peptic ulcer disease generally comes from, we talked about ulcers and stress, and the mucosa will erode away, and then that becomes inflamed. And then what happens is you don't want to eat, maybe because it hurts, or you have signs and symptoms of things after you eat. Maybe you're diagnosed with an ulcer, and so then you don't want to eat. And so then that can lead to malnutrition. We talked also about cholecystitis and cholelithiasis, as well as cholestasis, cholestasis of pregnancy, in terms of that the bile flow is obstructed. And so because of that, then it's difficult for the body to digest fat. And so you can get fat in the stool, right? Because it isn't being digested, it isn't being reabsorbed into the body. And so you can have fat soluble vitamin deficiencies as well. Lactose intolerance, I'm not as concerned about as well. And then celiac disease, we did talk about, that was the villi, right? And so in celiac, the villi become, they're supposed to be fingers, right? Like anemones, and they become flattened. And so then they can't absorb the nutrients. And so that can turn into malnutrition. And so the gluten is what triggers the atrophy, which is why you don't want to eat gluten. You want the villi to be able to absorb the nutrients so that you're not malnourished. And then also talking about post-gastrectomy, bariatric surgery, weight loss surgery would be another term for that. And in terms of, there's different types of surgeries. I don't necessarily need you to know the different types of surgeries, but basically what happens in terms of nutrition is that there's less, the gastric capacity decreases, right? Because usually there's some kind of workaround, or we're making the stomach smaller. And so then what happens is you can actually get dumping syndrome, where everything just comes out. You have bowel movements and, usually because you're eating more than what the stomach can handle. And so you get dumping syndrome, which again can lead to malnutrition. So that's kind of why this category is about nutrition, because there can be some parts that have inflammation, but also most of these can lead to malnutrition, which is not good. We want to be well nourished. So then if you're looking at specific like clinical manifestations, so what are you noticing? What do you see in your clients, right? And so with GE reflux, and you have GE, you have GERD, you have gastroesophageal reflux disease, which is a chronic type thing, or you just have GE reflux, gastroesophageal reflux, which just sort of comes and goes, or you have one little episode of it, but it's not a chronic thing. And that's the difficulty swallowing. You might have a chronic cough because things keep coming up. Heartburn is another big thing. And oftentimes heartburn can be confused with ulcers as well as heart attacks in some people. So sometimes people will present to the ED because they have heartburn, but they thought it was a heart attack. But I figure better safe than sorry. Again, not talking about pyloric stenosis, peptic ulcer disease, kind of the same type of thing, epigastric burning pain, nausea, totally just forgot what melena is. I have to go back and look that up. Not so worried about that. And then what was the other, oops, sorry. Just lost my place. Sorry, there we go. In terms of celiac disease, right, the chronic diarrhea, weight loss, maybe abdominal distension. So they kind of sort of, with celiac, there's not the heartburn kind of burning type pains, but the diarrhea, the abdominal distension, fatigue, those are really big with the celiac disease. To me, that one's the one that's presenting with the more malnourished type symptoms because the body's not absorbing. Oh, thank you, Brad. Blood and stool. Can I zoom in on my screen, like make it bigger? Is that better? How's that? Yep, no worries. And so people with chronic diarrhea need to be on PO potassium potentially. Yeah, I mean, they would have their labs checked, right? Because diarrhea, you're going to lose potassium, sodium, a lot. That then becomes a fluid electrolyte issue. But we would want to monitor for sure, and then they could be on PO potassium, definitely. And then what we didn't talk about was the post-gastrectomy type of the clinical manifestations. You see the dumping syndrome. There's usually an increased heart rate and perspiration, sweating. And then you can have B12 deficiency signs as well. The best thing to do is like small frequent meals for that. That's much better, but it takes time to figure out how much and what kinds of foods. And sometimes what'll happen is they'll do, as nurses, we do the discharge teaching, but then the person gets home and then they eat too much or they eat a food that's going to sort of is not compatible. And so like it used to be, because you really have to change the whole way of eating. That's why I think gastric surgery is, it's really important to look at all the pros and cons and your particular lifestyle to see if that's a good choice for you or not. We talked a little bit about different diagnostic procedures. So the client comes, they're complaining of heartburn, pain, or maybe distension, things like that. And so we talked about being able to do an upper GI endoscopy where they put the camera down the throat and go down the esophagus. They can check and see if there's any issues with the with the esophagus, and then going in to see if there's any obstructions or growths, and you can see the ulcers, and so they can diagnose that way, which is good. You can also do the upper GI series in terms of barium. So that will light up on an X-ray or when they're doing that testing to see mostly if they're you can see if there's like blockages or narrowing, and then you can also watch because you're swallowing it, and then if there's reflux, it will actually come back up and you can see it on the camera. We talked briefly about H. pylori, so there's the urea breath test that you can do. Abdominal ultrasounds, those can find gallstones. Labs, like Alex was just saying, talking about potassium supplements, looking at anemia, which is a big thing, the electrolytes. You could do fat studies to see if the fat is not being absorbed. Not going to worry about the lactose tolerance test. Celiac panel, no. You can do biopsies, especially for celiac disease, to see if how the villi are performing. And those are pretty much, yeah, the upper GI, the barium labs would be the basic ones to know. And then when you look at different types of the nursing and collaborative interventions. So if we are talking about in terms of pharmacological therapy, I'm not as interested in that. If there are specific ones I want you to know, I'll let you know before the final. But you guys have already been tested on a lot of these already, right? Because you did the proton pump inhibitors and all that kind of thing. So there are the proton pump inhibitors, the H2 blockers, which is very similar for GERD and for the peptic ulcer disease. We did also talk about antibiotics as well as the proton pump inhibitors and H2 blockers. So it's the same type of thing because they have the same types of symptoms. But then with the H. pylori, you're going to add the antibiotic. Cholecystitis, any type of thing with the gallstones. If there is an infection, obviously antibiotics, analgesics, because it's very, very painful. I think, what's the other name for ketorolac? Toradol, yep. And so why would they want to give Toradol as opposed to, I don't know, PO acetaminophen or PO Motrin? You'd be talking like in the hospital. Yeah, inflammation. It's usually an IV push, and so it's we can give it takes effect quicker when we're talking about being in the hospital. And then it's also not going through your gut if it's going in IV. Celiac disease, unfortunately, really doesn't have any medications. It's more of diet, right? Diet control. And then for the post-bariatric surgery, medications that can slow the emptying if they have dumping syndrome. So antispasmodics, which will help the gut from contracting and pushing everything out. So if you calm the gut down, then you're able to retain better. If you are having a lot of diarrhea, vomiting diarrhea, nausea, not feeling well, the IV fluids are very important. If you're in the hospital, oral rehydration, like electrolyte things, like Gatorade, they have all kinds of different oral rehydration fluids, but those would be at home, those would be the go-to. And then, potentially teaching the client what are signs and symptoms of dehydration. I would focus probably more on understanding why we use oral rehydration solutions. And so then what specifically types of diets or supplements. We talked a little bit about B12 for the dumping syndrome. A lot of these are going to be small, frequent meals, finding those trigger foods that make it worse and avoiding those. Avoiding caffeine. For the cholecystitis, low fat diet, again, small, frequent meals. So there's a pattern here, right? If we're looking at these types of problems and we're looking conceptually, a lot of the interventions are very similar. And then for celiac, the gluten-free diet, and then supplementing iron, folate, and then again, small, frequent, high protein meals, and fluids between meals. Yep. Okay. And then different surgical interventions. I'm not, yeah, no, not going to worry about surgical interventions. So we can just cross that part out. Yay. And then as always, the therapeutic communication, right? The psychosocial self-management things, you know, can be pretty embarrassing if you're going out to eat and you can't eat certain things, or if you, you know, feel nauseous when you go out to eat. You know, finding support groups, setting realistic expectations. I think food diaries are always a good idea to figure out what triggering foods are. See if you can figure those out so you can avoid them. You know, educating people to read labels really well, although a lot of times things aren't always on the label, which can be a problem. And I think cultural, religious food preferences are, always something to take into consideration, because if it's something that they've been eating for a long time, like we talk a lot about when you go to Clínica de Salud, right? And you're talking about to the client about they have diabetes, right? And so you're trying to cut out either sweets or so many carbs, but you know, maybe we can ask you know, smaller tortillas or whole wheat tortillas, things like that. But you know, maybe margarine instead of lard, you know, different substitutions that we can make. But when it's something that you've been doing or that your family does, it's really difficult to take care of yourself in the way that you need to. So I think it's always good to keep that that in mind. And then I just put some key things about bariatric surgery and dumping syndrome. Don't care about that. What I am looking at, and I think what I might do is I'll go back and highlight the study guides for where you need to focus, and then I'll re-upload them for you. Yep, I will do that. And in terms of, you're welcome. In terms of doing the assessment and the education, and what the post-op, they talk about pre-op diet, but what are we going to do for post-op as well? And then when you are talking about bariatric surgery, well, if we talk about that, I can do that, no worries. I'll try and go back through all the study guides and do all that. And yeah, I know, I get it. No worries. And remember, we will have a Sully Sesh before the final, right? Where everything will be really, at least that's my goal, is to really hone it down for you so that you know. Post-op, like say you're appendectomy or something in the hospital, right? You, like clear liquids to start with, advance the diet as tolerated, and it just kind of, by the time they're going home, they're on what they're going to eat at home, generally speaking. And then but with bariatric surgery, weight loss surgery, it's really you can see it's over weeks that they're trying to advance the diet as tolerated. So clear liquids for even the first week. So that's really difficult for someone that's used to eating solid foods. It's really difficult to go to the clear liquids. Then you go to full or pureed, and that's for another 2 weeks after that. And so really a lot of protein fortification with that to keep up muscle mass as well. And then moving to soft foods and then regular texture after 6 weeks. That's a long time. And so then also remembering supplements, to have supplements, because everything is absorbed differently after the surgery. So I would focus more on the diet progression, not as much, I mean, maybe with the supplements, but not as much. I mean, it's basically vitamins, multivitamins, iron, vitamin B12, just a really good, strong multivitamin with minerals. And then we're going to keep doing labs. And then, because we had surgery, and so what complications are we looking out for? And so these are things that as nurses, you are going to do in your discharge teaching, right? So early on, anything that you would find post-op, right? Bleeding, infection, that kind of thing. But then later on, excuse me, there can be more like the dumping syndrome would be something you could potentially get gallstones. So just to be aware of that. To do fluid level management, right? So we talked about fluids, electrolytes, we talked about that. Pain and mobility, that's post-op, right? So there's, again, overlap with things that you have learned already. And then meal planning, I think meal planning probably is one of the most important things because a lot of the eating habits that people have are just like, oh, I'm going to grab this or I'm going to do this, pick this up here, pick this up here. But with this, you really have to plan ahead. You have to be very conscientious of the amount and the type of food that you are going to be eating. And the follow-ups, the psychosocial, you know, you're going back to the doctor quite frequently to check and see, make sure everything's going okay. Again, lifestyle changes, behavioral strategies. I had a friend that I worked with at Chomp, who was, I didn't know her when she was heavy, but she had showed me a picture and I'm like, oh my gosh, I never would have thought she was ever that heavy, because she's this little itty bitty tiny, like 5 foot, nothing, skinny person. But she had meal prepped. She would bring her meal. She worked night shift. We worked night shift in the nursery and then in the NICU. And she always had the same meal. She had maybe 2 or 3 different choices, but it was always one of those 3 choices that she would bring. And she was like, she never deviated. She was just that into, like, this is what she had to do to do this. I decided against doing bariatric surgery because there's no way I could follow something like that. I'm too, I spin too much and I'm too wishy-washy. So, I've tried other things in that, but you know, it's not like I could say as a nurse, well, no, you need to do this, or yes, you should do this. You give pros and cons and the client decides. And then there's information on the dumping syndrome. Again, I will go back and highlight the things that I would like you to focus on. But again, if you're dumping things, then the nutrients aren't being absorbed. The sugar, you might have glucose problems. So that can be a side effect as well. The small, frequent, high protein meals, and they don't want you to drink with meals. They want it before or after eating. And because if you drink during meals, it can how do I want to say it? Like the food can absorb and it gets more, it's more bulk. And we don't want that. We want the food to go in, get absorbed as much as it can, and then we can drink before or after that. And then in order to help with dumping syndrome, you can lie with head of the bed up a little bit, or lie down so that gravity isn't working and things are kind of going along evenly, which is kind of an interesting concept, I think. Okay, and then education point, yeah. Not worried about any of that. I think everybody's brain is fried. No worries. Okay, so we covered, let's look at the lesson. So again, looking at signs and symptoms, what do you notice? Any diagnostics? Yes, so yes, because yes, because the insulin's coming out to process the sugar, yes. And then, yeah, I'm just gonna say yes, because that is totally what we just talked about, or what was on the study guide. And that's a problem because somebody that, I mean, being overweight, the person may already have had type 2 diabetes. That's a possibility. With the surgery, hopefully that will go away or can be managed really, really well. Bringing the labs down and the A1C down. But with everything dumping, then yeah, that's on many different levels. Yes. So that's something to teach people as well. Okay. Let me go. Let's do stop share for a second. I bet everybody's glad we're recording this so you can all go to bed soon. Okay, let's do bowel elimination, since we were kind of talking about dumping syndrome, and then we'll go back and talk about urinary elimination. Oh, that was not the one I wanted. Let me find the one I want. Not that one. Elimination. There we go. Make that bigger. Sorry, just trying to move stuff around here. Let's go to back there. Let's go back and look at the lesson. Oh, and I was going to, had told people in Success, but the community paper due date got moved back a week. So you have another week to work on that. So for, hold on one second. Too many windows. There it is, share. And that one, share. Okay, so we are on the bowel elimination lesson. The PowerPoint I think is good. Again, just running through these different the different disease processes in terms of looking at them in terms of nutrition, looking at them in terms of elimination and inflammation, right? Those are the things that we're really focusing on. And pain would be another concept, right? Because there can be a lot of pain with these. Let me look at, we'll do that, and that one, we talked about that. The Crohn's and the ulcerative colitis are big ones. Let me do this. Let me move this over. So do you see the study guide now? The updated study guide?
Yes.
Yes, thank you. Chat up. There we go. So basically this is a I guess kind of a table in terms of talking about Crohn's and ulcerative colitis, which really are the things that we're focusing on, as well as appendicitis and bowel obstruction. We didn't talk too much about IBS, irritable bowel syndrome versus irritable bowel disease. I'm not too, I mean, I'm I'm not too focused on that. I might end up being, but not really. Again, understanding that the disease is way more chronic than the irritable bowel syndrome, which is the constipation, diarrhea, now you're constipated, now you have diarrhea, and there is not an inflammatory component, which is why I don't necessarily think it fits in with this lesson, because there's not the inflammatory component. However, to know in terms of the Crohn's versus the ulcerative colitis, right? What is the ulcerative colitis? What's the difference? How do you tell the difference between the two? In terms of where it is in the intestine, right? Distal end of colon is for the ulcerative colitis, right? And then the Crohn's is like throughout the intestine. It can be small bowel or large bowel, right? And so if you're talking about nutrition, especially in the cold, let's do ulcerative colitis, right? So if you're talking about the end of the digestive tract moving into the rectum, again, like the Hirschsprungs, same type of thing, right? Blood loss, malnutrition, bloody diarrhea, inflammation of the colon, the colon and rectum area only, left lower quadrant pain that usually feels better after you have a bowel movement, whereas Crohn's is more of a malabsorption, because you're also in the small intestine, not just the colon, and so malabsorption becomes a problem. And so more liquid stools may have blood or mucus. Again, they call them the skip lesions because they're going, this part, and they skip, and then they are in this part of the intestine. More of a cramping right lower quadrant pain versus the left lower quadrant, because you think about anatomically where the end of the colon is, that's the left lower quadrant. If you think about right lower quadrant, that's opposite of that. Appendicitis isn't really, I don't really think of appendicitis. To me, that's more of like a pain thing. It is an inflammation, but it would be more pain and infection that I would be thinking of. And because of the surgical procedures, then you can get paralytic ileus afterwards as a complication. You're looking for the rebound tenderness. That's usually the sign that there is appendicitis. And then what might be a sign that the appendix had perforated?
Sudden relief.
Yeah. We're not talking about the congenital defects because we already covered those. And then for this particular lesson, right? And then the bowel obstruction, depending on where the obstruction is, again, could be ischemic, inflammation, kind of pain might be on and off depending. I always think sometimes of a bowel obstruction too, depending on where it is. Sometimes you can get some liquid that comes around it. So you might have really watery stools, not a whole lot, but oftentimes the fluid can get around that obstruction for a while, and then you don't have any stool. And then when we look at in terms of, understanding it or recognizing it, what are we noticing? We kind of just talked about that in there, the McBurney's point, right? The right lower quadrant pain. That's kind of the same thing. And then different diagnoses, different diagnostic procedures that we can use. We can look at, obviously, if there's infection, right? We'll see that in the CBC with the increased white blood cell count. You might have a CRP or SED rate. The ESR is the SED rate. Excuse me, when there's inflammation, you might see problems in the electrolytes. Maybe decreased albumin with the malnutrition, decreased protein, decreased albumin. Again, we can do an upper GI series if that's needed. We can also do, gotta love those colonoscopies. I think I'm due for one again. Every 10 years after you hit 50. But it's very important to have those done for diagnostic purposes. And I believe you can do the, what is it? The Cologuard now, the little colon kit guy that walks around. So you can do your own testing if you don't have a history of it or any of the high risk factors for that. Barium enemas are not fun either. And then of course, x-rays, CT scans, those are always diagnostic. I am not so much worried about medications. Other than antibiotics and steroids, but if there's something specific, I will let you know. Mostly I would focus on the dietary management in terms of, which we talked about in the week 13 quiz that you did, right? In terms of the high fiber, low fiber, for exacerbations, the low fiber, otherwise high fiber is okay. High protein, high calorie. Again, same with the peptic ulcer disease, like find those trigger foods and try to avoid them as much as possible. And again, that's where a food diary can come in handy. Sometimes you might have to do enteral, like NG feedings, or parenteral, TPN and lipids, those types of things for malabsorption, because sometimes we have to give the bowel a rest. Sometimes we also, that's why colostomies came along at the same time in skills. Remember to get those turned in. Because we have to give the bowel a rest if there was something that happened. Whoops, I do not know. I have a ghost here on my computer or something. It keeps moving there. And then so enteral TPN bowel rest is always a good thing. So for us as nurses, so say we have a client come in, they are diagnosed with a bowel obstruction, what are we going to do for nursing interventions and evaluating effectiveness of treatments? So we're going to, like we do with babies, abdominal girths, we can do abdominal girths, always checking those bowel sounds. Like that abdominal assessment, I think we tend to think of it as, like respiratory cardiac, that's where it's at. But if this is the problem, then we've got to be able to, figure out if they're distended more or less than they were before. What are the bowel sounds? If they have an NG to suction, what's the output? What's it look like? The COCA of that. And in terms of pain and comfort, that's all, especially post-surgical for appendicitis. And again, the diet modifications, the lifestyle measures. And again, like you all had pointed out in class, again, if you constantly have diarrhea, you constantly have to run to the bathroom, that's a problem, and it can be difficult to be out in public. So there's a lot of teaching to be done there. What else? And then this is the same practice questions that you have in the module with the key as well. What else was I thinking? Right, Crohn's disease, right? And Crohn's is systemic throughout the body. That was the other thing. Not worried about diverticulitis, diverticulosis. Celiac is there. Yeah. I mean, I feel like we've covered that. And then what else? Okay. And then let's move on to, I do not know what is wrong with my mouse. Stop sharing. All right. And then let us move on to urinary elimination. Yay, the fun stuff. Yeah, that was a good suggestion, Hunter. I think nutrition went into bowel, and then now we can, whoops, yes, Hunter is still there. Move into, whoops, urinary. Dun, dun, dun. Urinary elimination and inflammation. Urinary elimination. There we go. So what were the exemplars for urinary elimination? The key ones to focus on. Yep, nephrotic syndrome. Nephritis, yeah. Glomerulonephritis. And so, let me look real quick here. Okay, let me go ahead and share. I think we're making good time here so far. And I will, I'll run once I get the video, I'll run it through YouTube and then I'll post it in the modules again. So looking in terms of urinary elimination, we also talked about a few congenital defects, like the exstrophy of the bladder, hypospadias, epispadias, some of those things. And so sometimes even we'll have babies that are diagnosed with kidney problems in utero. Excuse me, they can actually, I guess, see the kidneys in there and see if there is potentially what they call hydronephrosis, which is a fluid overload and either in the kidney or in the ureter itself. But basically to understand what in terms of the acute, again, we're talking acute here. There are also chronic, these can be chronic, but those, we're just looking at the particular acute incidents here. And so remember that the functional unit is the nephron in the kidney and the glomerulus is part of that filter. And so if you have glomerulonephritis, so that's an inflammation of the glomerulus, you will get a decreased glomerular filtration rate because the kidney, that part of the kidney is not working to filter what it is supposed to filter out. And so what you end up with is that tea-colored or cola-colored urine because it's not filtering out the things that we don't want. And then, yeah, glomerular inflammation, you end up with fluid retention. So there's edema, hypertension, things that come with that come with fluid retention. One of the key hallmarks is the flank or back pain. There's not usually pain on urination. That would be dysuria. That would be more with a urinary tract infection. But the tea-colored urine for sure. Nephrotic syndrome is because the nephrons are not working correctly, can be from trauma, but because there's for the nephrotic syndrome, you get the frothy urine because there's a lot of protein coming out in the urine. So there's more protein in the nephrotic syndrome. So you also get, because you're losing so much protein, you can get, they call it anasarca, massive edema from the hypoalbuminemia. So there's decreased protein, and so that means there's also decreased albumin. Not as painful, whereas the acute glomerulonephritis will have the flank pain. So we talked about that. This looks kind of weird, but for the, let's look at, what do we want to say? So again, nephrotic syndrome, the proteinuria, the hypoalbuminemia. You see a lot of the edema around the eyes, the periorbital edema, as well as ascites, which is like third spacing of the like the fluid in the abdomen. And so with ascites, the stomach, abdomen actually kind of sloshes side to side. like it kind of moves. That's kind of how I like to explain that to students. You will get that frothy urine because of the protein. You might also have increased lipids, hyperlipidemia. The key hallmark things for the glomerulonephritis would be the tea or cola colored urine. Again, there is edema, and you will tend to have hypertension with that and more blood, mild proteinuria, some protein, but mostly blood, which is another reason you have the tea or cola colored urine, because it's not filtering out any blood that's there. And then our urinalysis, right? That's where we're getting all this information from. The increased BUN or creatinine, because the blood urea nitrogen, that's what the BUN is, or the bun, I guess, as people say. That to me, I don't want urea, right? That's a bad thing. So if I have an increased BUN, then that means my kidneys aren't functioning very well. That's also why it's a hallmark of kidney failure. You might also have electrolyte imbalances. You can do ultrasounds that can be diagnostic to see, for example, where is the inflammation? Because what will happen sometimes is that you get a urinary tract infection, which will then back its way up into the kidney, going through the ureters to the kidneys, and then that's why you're getting the inflammation because of an infection. And so the ultrasound or different tests can show you that. And then what else? And then for the nursing, things that we're going to do, again, pharmacological therapies. Now, remember, as you may or may not remember, that the glomerulonephritis often follows a strep infection. So does anybody remember what lab or what titer might be elevated? Oh, sorry, Hunter, I didn't see that. Not based on labs, acute kidney injury, yes. And then do more tests to see what exactly it is. Yes, pretty much. And so I think as nurses, we're looking more at the symptoms and treating those and letting the providers know what we're seeing. And then they can do more tests to figure out what exactly it is. We could say from the symptoms that that this is what we think it is, but again, our job is not to diagnose, but yeah, acute kidney injury, yeah, AKI, not a chronic kidney disease. So the is there a particular lab or titer that we can check if we're trying to figure out glomerulonephritis versus nephrotic syndrome? Has some letters in it, like 3 letters.
Not CRP, is it?
No, not CRP. That's the C-reactive protein. Starts with an A. ASO titer. Yeah, so the ASO titer is a titer that we can do that will let you know if there's been a streptococcal infection. And so then that would lead us down the glomerulonephritis pathway. So that'd be good to know that. So diuretics, right? Antihypertensives, those types of things. So if you have an infection, you have inflammation of the kidney, the glomeruli, the nephron, it can't do as much work as it's used to doing, right? And so are we going to push fluids, or are we going to restrict fluids?
I would say restrict.
Yeah, restrict fluids. And then also sodium, because sodium and water follow each other. And sodium restriction, diuretics with meals. But we don't want to fluid overload them because they're already fluid overloaded. So that's why we have the diuretics. checking the blood pressure, for the hypertension and the glomerulonephritis, the intake and output. So oliguria is different than anuria. So anuria would be no urine output. Oliguria is decreased urine output, and the less than 0.5 mLs per kilo per hour is the guideline for that. Daily weights, always, right? Daily weights, I'm sure first semester, daily weights, right? Best measure of fluid status, and see where the edema is. Always daily weights. And then, of course, the type of edema. Is it pitting edema, non-pitting edema? Where is it exactly? Is it around the eyes? Is it the ascites? Where is it? The regular measures to prevent skin breakdown, making sure that they're taking their medications, finishing the antibiotics, working with nutrition, dietary to work on low sodium diets. I think sometimes we do a disservice, especially if the client's in the hospital, because we'll say, oh, here's your handout on a low sodium diet. Hopefully we do a referral to the to a dietitian or nutritionist. But again, you have to take into account, you know, cultural, religious preferences. What have people been doing? Social determinants of health, right? What is the cost for specific types of food? Having them do their own weight checks at home. And when would they need to ask for help? Maybe we've got them doing besides the daily weights, maybe they're checking their blood pressure, right? We could do a use a home blood pressure monitor, and that would help. But any increase in edema, urinary output decreasing even more, hypertension, why would they have difficulty breathing?
The fluid accumulation.
Mm-hmm.
It's
Yep.
too much weight.
Yep, you got it. And then there's those practice questions. So that kind of, I guess, in a nutshell, is the things that kind of those key points, those key exemplars that for you to look at. Like I said, I will go back, not tonight, but I will go back and try and I will highlight the things for you specifically to focus on, and repost those. And what else? And then Thursday I can do a Sully Sesh for if you want to talk about the spinal cord injuries and the seizures. I'm going to try and go over seizures a little bit on Thursday when we talk about stroke and intracranial pressure, increased intracranial pressure. But then I think we'll have gotten through most of everything. And what else? And then Miss Clark and I are working on the exam questions. And yeah, and so next week, I can't promise Monday, but maybe Tuesday, Wednesday, I'll do the Sully Sesh to prep for the final. Any more questions or anything? That's not bad. 3 topics in an hour that time. I'm gonna stop the recording. Stop the recording, there we go.